So, as Seema ma'am has already pointed out, the main symptoms of uterine fibroids are heavy menstrual bleeding, abnormal uterine bleeding due to leiomyoma, that's how we coin it nowadays, pelvic pain, bulk symptoms, and the patient may also come to us with reproductive failure. But simultaneously, approximately 50 to 70% of uterine fibroids are asymptomatic, and therefore they require no treatment. The factors to consider when prescribing medical management to this young lady would be, what are the characteristics of the uterine fibroid, what is the type, what is the location, the size, if there are any multiple fibroids, if there are any coexistent uterine disorders such as adenomyosis, endometriosis, what is the patient's characteristic, what is her age, whether she wishes to preserve fertility, whether she wishes to preserve her uterus, whether there are any other symptoms like iron deficiency or iron deficiency anemia. So medical management would be specially for those ladies in which the fibroid size is small, roughly around 5 to 6 centimeters. The main presenting symptom is heavy menstrual bleeding or AUBL. She has reproductive failure. She's had multiple abortions or she's unable to conceive. Preoperatively, when we would like to reduce the size of myoma or we would like to build her hemoglobin. If she's in the perimenopausal age group, if she's going to attain menopause in roughly another 1 or 2 years, she can avoid a surgery. And patient does not want any surgical option or surgery is contraindicated. And lastly, this is something new that I read, that is the evidence-based approach for secondary prevention of fibroids, that is after a surgery is done. So ESCAPE, that is basically we would like to supplement her with vitamin D, the upcoming role of vitamin D in secondary prevention of fibroid after a surgery has been done. So coming on to how does a fibroid actually cause heavy menstrual bleeding? It can be acting on the endometrium, that is there could be an increased endometrial surface area, there could be some molecular abnormalities occurring at the level of endometrium. There could be an aberrant angiogenesis. There could be alterations in the vasoconstriction of spiral arterioles. There could be impaired deserialization. Or if there are myometrial factors, then abnormal myometrial contractility, uterine venous ectasias, and dilated blood vessels on the surface of uterine fibroids. All these various factors can lead to heavy menstrual bleeding. If we look back at the physiology, then everything in our reproductive tract is controlled via the HPO axis. The GnRH pulses are released from the hypothalamus. They act on the pituitary to release FSH and LH, which thereby act on the ovaries to release estrogen and progesterone. So similarly, our drugs can act at various levels. So if we come to NSAIDs and tranexamic acid, they will directly act at the level of endometrium. If we come to levonorgestrel intrauterine system, that will also act at the level of endometrium. If we come to GnRH analogs like GnRH agonist, leuprolide, and what Deepti ma'am had just spoken about, relugolix, that's a GnRH antag, that will directly act at the level of FSH and LH. And then the last class of drugs, the selective progesterone receptor modulators, the famous ulipristal, which is outdated now, that will directly act at the level of uterine fibroid myometrium. So going through each class of drugs, the NSAIDs, they act by inhibiting the enzyme cyclooxygenase, thereby reducing the prostaglandin synthesis at the endometrial level, and therefore it will decrease both menstrual bleeding and dysmenorrhea. It is usually the first line of management prescribed by almost all gynecologists, and it is usually a combination of tranexamic acid, ethamsalate, and mefenamic acid. The next class of drugs is tranexamic acid. It blocks the plasminogen enzyme and thereby inhibits fibrinolysis, and can be given in both oral or IV formulations. It decreases blood loss by the tune of around 25 to 50%, and that is why usually it is combined with NSAIDs and given. It has a very favorable safety profile and is very well tolerated. So these were the two non-hormonal preparations. Coming on to the hormonal preparation, the COC pills, they have been traditionally used for decreasing heavy menstrual bleeding. There are several studies, but specifically for heavy menstrual bleeding due to leiomyoma, the studies are very limited. A COC containing estradiol valerate or a 17-beta estradiol combined with a progestin such as Dynogest or normegestrol acetate, they are very effective in reducing blood loss. Almost a 60 to 70% reduction in blood loss is noted over 6 months, but studies for AUBL are very limited. However, there is no change in fibroid volume and uterine volume. Simultaneously, there is a subset of us gynecologists who would like to say a no to a COC, especially in the case of fibroids, because it has both estrogen and progesterone, which are very well implicated in the growth of uterine fibroids. As Seema ma'am had explained, it is progesterone which is actually causing the growth of the leiomyoma, and estrogen is helping progesterone by increasing the progesterone receptors. So because the COC contains both estrogen and progesterone, there is a question mark whether it should be used in case of a fibroid. Secondly, fibroids will usually become symptomatic in ladies who are greater than 35 years of age, and it is that subgroup of ladies in which we need to be cautious, because they can have other medical illnesses too. So it really needs to be individualized. Coming on to the next class of drug, that is the LNG-IUS. This 52 milligram T-shaped LNG-IUS leads to a reduction in endometrial proliferation, and it leads to apoptosis in the endometrial glands and stroma, causes desterilization and atrophy within a period of 3 months. It leads to a significant decrease in the amount and duration of blood loss. But again, there is no reduction in the size of the uterine volume and the fibroid volume. It cannot be used in patients who have cavity distorting myomas, that is FIGO class 0, class 1, because of the increased risk of expulsion. But it is especially useful when uterine fibroid is presenting along with adenomyosis or endometrial hyperplasia. Coming on to the next class of drug, that is a selective progesterone receptor modulator. These SPRMs are actually agonists or antagonists. They behave in an agonist manner or an antagonist manner depending on the level of progesterone A and progesterone B receptors. So, although this is a very heavy slide, but these progesterone receptors are present all over our body. They are present in the breast tissue, they are present at the level of endometrium, they are present at the level of fibroids. So for fibroids specifically, this is the way that these selective progesterone receptor modulators will act. Uliprestol will have the maximum efficacy, followed by mifepristone, followed by the other 3 compounds which are not available. And this is another very heavy slide. So basically they will decrease the cell. So basically mifepristone, which is the only available drug right now, will decrease cell proliferation, increase apoptosis, decrease the extracellular matrix accumulation. Uliprestol was a wonderful drug, but it is now history. So, uliprestol is a selective progesterone receptor modulator. It impedes cellular proliferation, suppresses, last slide. Okay. So, the Pharmacovigilance Risk Assessment Committee of Europe in March 2018 found that uliprestol is associated with idiosyncratic liver injury. A warning was issued. And now finally in March 2025, Cochrane has come up with this fact that the use of uliprestol acetate and SPRM is suspended at this time because of an association with case of liver failure. So it is. Now what has happened, So the second SPRM that I can talk about is mifepristone. It has been very well there in the market. There is a Cochrane trial of 2017 which had 14 RCTs in it. Of course, there were around 5 to 7 RCTs of uliprestol, but 7 of them also belong to mifepristone. So mifepristone also reduces myoma volume, uterine volume, heavy menstrual bleeding, pain, intra-op time. It improves the hematocrit, hemoglobin, as well as the quality of life. But again, because it is a selective progesterone receptor modulator and all these are excreted via the liver, a monitoring of an LFT is a must, both at the start of the treatment, during the treatment, and after the treatment. The SPRM associated endometrial changes, which has been another area of concern, they are benign, non-cancerous, and get reversed after 2 months of stopping treatment. So I think mifepristone will stay in the market, especially because of the cost factor. It is easily available drug, and there are at least 7 RCTs which have been included in Cochrane. So this was a comparison of an SPRM with leuprolide acetate picked up from Cochrane, but this was done on ulipristal. So it just compared ulipristal versus leuprolide. It said both of them are equally efficacious, but now this is history. The fourth class of compounds I would like to talk about is letrozole. Seema ma'am had explained that these fibroids also express the enzyme aromatase, and because they express the enzyme aromatase, the androgens are converted into estrogens, and that is why there is an increased leiomyoma growth. So if we stop this enzyme aromatase inhibitor letrozole, then again we would notice a decrease in myoma size, myoma volume, heavy menstrual bleeding. The dosage would be again 2.5 milligrams per day for 12 weeks. Also, it is associated with an improvement in preoperative hematocrit, a decreased intra-op time, decreased blood loss during surgery, also a decreased fluid absorption in hysteroscopy if we are dealing with FIGO 0 or FIGO 1 classification of myomas. But the studies are limited. Cochrane just has a single center RCT study of 70 patients. So there are no guidelines as per se, for treatment of fibroids. The last class of compounds that I would like to talk about is a GnRH agonist. So when we give a GnRH agonist, there is downregulation of pituitary GnRH receptors, thereby decreasing the FSH and LH production, which will ultimately stop the gonadal steroid production. Again, therefore, there will be a decrease in the size of fibroid volume, uterine volume, and improvement in the heavy menstrual bleeding and the quality of life score. But because we are completely shutting down the HPO axis, this is associated with a lot of hypoestrogenic side effects, vasomotor symptoms, vaginal dryness, sleep disturbance, myalgias, arthralgias, mood swings, and cognitive impairment also. Besides that, it also leads to bone demineralization and a decrease in the bone mineral density. As much as a 6% loss in bone mineral density has been noted after 6 months of treatment. Therefore, add-back therapy was added to GnRH agonist with estrogen or progesterone or both, plus calcium and vitamin D, especially if we are wanting to use a GnRH agonist for more than 6 months. So GnRH agonists nowadays are recommended only for short-term treatment of uterine fibroids related AUB and HMB, and as a bridge to other treatment strategies. It could be for prior to surgery, or if she's going to have menopause in another 1 or 2 years, or if we are planning to switch to any other medical therapy. GnRH antagonists, ma'am has already spoken about. We have had, previously we've had elagolix, now relugolix, and linzagolix is still not available with us. They seem to be effective in treating heavy menstrual bleeding associated with uterine fibroids, and these new drugs are also have to be combined with add-back therapy. So for medical management of heavy menstrual bleeding and fibroids, we have tranexamic acid, oral and IV, NSAIDs, OCPs, levonorgestrel intrauterine system, SPRM, that is only mifepristone, aromatase inhibitors letrozole, GnRH agonists, and GnRH antagonists. Thank you so much.